Yeah. So you guys can see my screen, right?
Yes.
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 Yep. Okay. Perfect. So okay. Yeah. So there are four medications that I want to talk about today. So and all of these are pretty well known. So we have warfarin, we have heparin, we have direct factor 10A inhibitors, and then direct factor 2A inhibitors. Okay. So we have all of these medications that we want to talk about. Now, couple of things. Let's start with let's start with heparin first. Now, what heparin does, right, is it activates a very specific molecule. It activates a molecule called AT3. Now, this molecule is called antithrombin 3. And now, what do you think? Simply based on the name, what will antithrombin 3 do?
Will
Inhibit
inhibit.
thrombin.
It will
Yes,
inhibit
Inhibit
thrombosis.
from.
perfect. It says antithrombin. That means it's inhibiting thrombin. Now, thrombin is a factor 2. It's factor 2 or factor 2A if it's activated. Now, that's the entire effect of heparin. It inhibits factor 2A. And along with that, one thing that we do need to remember that it also inhibits factor 10A. These are the two molecules that heparin inhibits. Now, why? Because it starts with antithrombin 3. Simple, right? That's the entire mechanism of action of how heparin works. But the USMLE, they're not very nice about this. They want you to remember multiple things. So classic heparin, if it's unfractioned, it will inhibit the action of factor 2A and factor 10A. Now, sometimes what happens is unfractioned heparin, it's a much bigger molecule, and you don't want to inhibit both of these factors because then you have a much higher risk of bleeding as a side effect. So what you do is you make the molecule a little smaller, and then you have low molecular weight heparin. Now it's low molecular weight. That means we've reduced the weight. It doesn't do all of the effects as heparin, but it is still as effective. Now, low molecular weight heparin, it blocks only one protein and one factor, which is factor 10A. So low molecular weight heparin binds factor 10A, while heparin, which is the unfractioned form, binds antithrombin 3, which then reduces the effect of 2A and 10A. So any questions until now?
Please, can you please repeat the low molecular weight? It's where it binds to. Please repeat it. I do not really get it. Thank you.
Yeah, sure. So let's assume the two variants of heparin, right? So we have unfractioned and we have low molecular weight. Now, unfractioned heparin has let's assume this, that it has a molecular weight of 10,000. A low molecular weight heparin will have a molecular weight of 100. Now, why is this better? Couple of things. Because unfractioned heparin will inhibit both the factors. So now you have a much higher risk of bleeding. So that's why you can give the patients unfractioned heparin. Unfractioned heparin will also cause reduced viscosity of the blood. That's one reason. Plus, it produces less of a strain because it's only inhibiting factor 10A. Those are the
Okay.
reasons why you give low molecular weight heparin. And if
Okay.
you were to talk about the effects, unfractioned heparin will inhibit antithrombin 3, which then inhibits or decreases the effect of factor 2A and factor 10A. Low molecular weight heparin, on the other hand, will inhibit factor 10A. Now, so this is the general idea. Now, there's one more thing that you need to remember about the difference between these. Low molecular weight heparin, it is water soluble. So it is water soluble and renally excreted. Now, uh, because low molecular weight heparin is renally excreted, what condition do you think we should not give low molecular weight heparin in?
Kidney failure.
Kidney failure, yeah. So acute kidney failure or acute kidney injury, chronic kidney disease, all of these conditions you do not want to give low molecular weight heparin. So then if we cannot give low molecular weight heparin, what medication should we give these patients?
Warfarin.
Okay, yeah, technically you can also give them warfarin, but unfractioned heparin would be much better than if the patient has CKD. Now, after all of this is done, let's talk about general effect of heparin. Now, heparin is an anticoagulation agent. And that just means it reduces coagulation, right? So if heparin reduces coagulation, what's one of the first side effects that you can think about? If you have low coagulation, what's the first side effect that comes to mind?
Bleeding.
Bleeding. Yeah. So we have bleeding. Now, the second side effect of heparin, right, is that you can develop an allergy. And I use the word allergy a little lightly. So I'll add allergy in quotations. And this allergy actually is an IgG mediated condition, which is called HIT. Now, the full form of HIT, it's actually heparin induced thrombocytopenia. Okay. So it's an IgG mediated condition, which is heparin induced thrombocytopenia. Now, simply based on the name, what can we figure out? It was induced by heparin. So you gave someone heparin and then you developed thrombocytopenia. Now, why did you develop thrombocytopenia? Because you developed a IgG antibody against platelets. So once again, heparin-induced thrombocytopenia, the entire idea behind this condition is that after the administration of heparin, you develop thrombocytopenia, which is low platelets. Now, why did you have these low platelets? Because you were producing an IgG antibody against the platelets. Now, there is one thing that you need to remember, that this antibody, it's not exactly against the platelets. Sorry, it's not exactly against the platelets, but it's against the molecule, which is heparin and then platelet factor 4. This complex, which is present on the surface of platelets, is what this antibody is produced against. Now, what do you think would be the symptoms of heparin-induced thrombocytopenia? Let's say we develop thrombocytopenia, which is low platelets.
Superficial bleeding, such as purpura, petechial.
Yeah, so we have
Ecchymosis.
petechial purpura. Okay, we might also develop ecchymosis if it becomes severe. That's one. What else? Maybe something else. Think about epistaxis. Maybe you could develop epistaxis. But if you were to sum all of this up into one condition, that would be you'll have, again, bleeding problems. So how do you think the USMLE will test this? The USMLE will tell you, okay, let's say someone came in with a PE. You treated the patient. Now patient has bleeding. So what condition caused the bleeding?
Heparin.
Heparin, yeah. So HIT was the reason. Now, obviously, you had pulmonary embolism. And for pulmonary embolism, okay, this is an interesting question. For pulmonary embolism, do you need a fast-acting medication or a slow-acting medication?
Fast acting.
Fast acting required.
Fast-acting, yes. You never want to give slow-acting medications because patient cannot breathe anymore. There's no blood going to the lungs, and the lungs are at a very critical point where they can just like die off. So you want to give something fast-acting, and the fast-acting medication is actually heparin. Now, if you give someone heparin and they can develop the immune complex, so they'll develop an immune complex, which is IgG against platelet factor 4. And this coagulation or this complex will then lead to bleeding. Why? Because you have low platelets. And this condition is called HIT. So any questions about HIT, heparin-induced thrombocytopenia?
Doctor, I want to ask you, what is the difference between HIT type 1 and type 2?
Okay, that's actually a really good question. So HIT has two types, obviously. So type 1 and type 2. Now, what we discussed about the thrombocytopenia, about this factor forming, which was the more severe complication, that was type 2. So this is associated with platelet factor 4 and the IgG antibodies. Now, platelet factor 1, HIT type 1, on the other hand, there is still a drop in platelets. So there's still a decrease in platelets. But there's two differences. One, you have no immunoglobulins. And second, it usually happens maybe 1 to 2 days after heparin.
Okay.
Now, why do you think this takes longer? This, let's say, would happen around 4 days in, or maybe 7 days in.
Because here
Why do you
the
think this
immune
takes too long?
complex will be formed. And
तबीयत
here
खराब हो रही है आपकी?
of immune complex.
Yes. So because you need to produce the immunoglobulins, because for producing the immunoglobulins, you need to activate the B cells. To do all of this, it takes time. And that is why it takes longer.
Excuse me, doctor. Can you please explain the last topic again, please?
So for HIT,
Yes, please.
okay. So HIT, basically it's the full form is heparin-induced thrombocytopenia. Now, based on the name, what we understand is that because you gave someone heparin, the patient developed thrombocytopenia, which is a reduction in platelets. Now, why did this actually happen? This happened because your body, it produced antibodies, which is IgG antibodies, against platelets. Now, the specific portion or the specific antigen that the body produced these immunoglobulins against was actually heparin and platelet factor 4. So this is the specific antigen. This one. That's the specific antigen against which the immunoglobulin is produced. Now, because you have a decrease in platelets, the most common problems that you'll have are bleeding problems. So you'll develop petechiae, you'll develop purpura. Maybe if it's severe enough, you can develop epistaxis. So all of these problems. And those are all associated with heparin-induced thrombocytopenia. Now, there's two types. The one we discussed right now, which has the production of immunoglobulins. That actually happens a little later, around 4 to 7 days after the administration of heparin. And that is because of the production of immunoglobulins. Now, there's another variant. This variant still has the reduction in platelets because the condition is called thrombocytopenia. But here, you do not have any immunoglobulin production. And then additionally, it also takes less time. So it can occur within 1 to 2 days of administration of heparin. Whereas the type 2, it takes longer. Now, why does it take longer? Because you need to activate the B cells to produce the immunoglobulins. That's why it takes longer.
Thank you so much, doctor. Thank you.
Now, there is one message which was added, which is what was the deal with kidney disease? Now, in kidney disease, if you, let's say you have decreased kidney function, if you have decreased kidney function, the amount of excretion will go down. So you'll have decreased excretion. In these cases, you do not want to give low molecular weight heparin, because low molecular weight heparin, it's renally excreted. And instead, you can give them unfractioned heparin. The UFH is unfractioned heparin. So any questions about heparin until this point?
No, doctor.
No, perfect. So there is one last thing that we need to talk about, which is that heparin does not cross the placenta. Now, what does it mean that heparin does not cross the placenta? What would be the clinical implication of this thing?
So it means
can
it's
be
safe
used
in
in pregnant
pregnancy.
women.
No fetal bleeding.
Yeah, so the idea is still the same, that it is safe to use in pregnancy.
It doesn't come from the mother to.
Yes, that it does not go from the mother to the child, and that's why the child is protected, and that it's safe to use in pregnancy. Now, one more thing that we talk about is that drugs which are safe to use in pregnancy or which do not cause any fetal malformations, they're non-teratogenic. Heparin is a non-teratogenic drug, both the unfractioned form and the low molecular weight form. Both of these are non-teratogenic. Okay, so that was all for heparin. Yes, I have.
Doctor, where is unfractionated heparin is excreted?
Oh, unfractioned heparin would be excreted by the liver.
Okay, thank you.
Yeah. So that is all for heparin. Now let's talk about warfarin. Yeah. So now let's talk about warfarin. Now, one of the first things that I want to tell you about warfarin is actually warfarin. It is a medication which has a low therapeutic index. Now, there are three medications that you need to remember which have a low therapeutic index. These are
Lithium.
obviously, lithium is one. There's one more.
Digoxin.
Okay, yeah, digoxin is one. And okay, actually, there's one more, sorry, which is theophylline. We don't use it anymore, but sometimes you'll come across this. So these are the three medications. They have a relatively low therapeutic index, so much higher risk for developing consequences and symptoms. Now, for warfarin. Warfarin inhibits a very specific enzyme, and this enzyme is called VCOR. C1. I mean, you can forget the C1 part. It's VCOR. Now, what does VCOR mean? It means vitamin K dependent gamma carboxylation enzyme. Gamma carboxylase, actually. So this is actually the enzyme. Now, based on this enzyme, there are a couple of things that we can extrapolate. One, that this medication, warfarin, it has something to do with vitamin K. So we can maybe indirectly say that vitamin K is decreased with heparin. or rather the effect of vitamin K is decreased with warfarin. Sorry, with warfarin. Now, there is gamma carboxylation. Now, what do you think? What would be gamma carboxylized? What substance can be gamma carboxylized by warfarin? Sorry.
I think
The clothing factors.
Yeah. So, gamma carboxylation of clotting factors.
Yes.
Now, there's multiple different coagulation factors which go down. There's obviously 2, there's 10, 7,
2, 7, 9, and 10.
yeah. Oh, sorry, I wrote 6. Yeah. 2, 7, 9, and 10. Yeah. Now, except for these factors, there are 2 more which are like 2 more which are decreased, and these are proteins C and S. Now, the simple explanation is that these factors, what do you think they'll do? Will they increase or decrease production of a clot? Are they anti or pro-coagulation?
procoagulation.
Pro-coagulation, okay. And what about these molecules, proteins C and S?
No, they will
These are
inhibit.
anticoagulant.
Anticoagulants.
Yeah, so these are anticoagulation. Yeah. So these are anticoagulants and these are procoagulants. Now, I will mark this with a red star because this is a topic we will come back to after we discuss the effects of warfarin. So now, we said that warfarin has to inhibit this certain enzyme, which is VCOR, which is dependent on vitamin. It helps in decarbox, and the enzyme VCOR is a vitamin dependent enzyme, and it helps in production or gamma carboxylation of these coagulation factors. So do you think this entire process, how long do you think it takes? Like, okay,
Days.
It takes time.
yeah, it takes days. As a general ballpark, it takes days. So compared to heparin, warfarin is longer acting. So if we were to just make a small difference here, we would say that heparin, quicker onset, and then also short half-life. On the other hand, warfarin has a delayed onset, but a much longer half-life. So this is an important point. Now, why do I say this is important? Because, we talked about these, that proteins C and S, they're anticoagulant, while proteins 2, 7, 9, and 10, they're procoagulant. It turns out that these anticoagulant proteins have a short half-life. So now, if you stop the action of VCOR, these proteins are the ones which will go first. Now, if you don't have the anticoagulant proteins, what do you think will happen to the body? If there's only, yeah,
There will be hypercoagulant state.
Hypercoagulation.
Short hypercoagulant state, and after
Transient.
that,
Transient
Yes.
hypercoagulability.
Hello,
Yes.
hello. Okay, please just raise your hand. So, like, as Dr. Taha is taking an amazing session, so we don't want students to be disturbed. So, those who want to participate, please raise their hand. Right?
yes. So
Can you
just
repeat
raise
this
your hand.
point?
Oh, sure. So if you have any questions, just raise your hand and I'll call your name and then you can ask the question. So before that, we'll just quickly recap everything that we've done. So we said that warfarin, it has a low therapeutic index. And the way warfarin works is that it inhibits a certain enzyme called VCOR. VCOR is vitamin K dependent gamma carboxylase. Sorry, yeah, gamma carboxylase. So because of the name, we know that this enzyme, it works with vitamin K. That means we can say that this medication decreases the effect of vitamin K and that it helps in carboxylation. Now, what is it carboxylating? It's carboxylating the coagulation factors. And the carboxylation of the coagulation factors is how you produce these coagulation factors. Now, there are all of these coagulation factors which need to be carboxylized. So factors 2, 7, 9, and 10. These are the factors. And these factors, they're considered to be procoagulant factors. That means they help in coagulation. And along with these factors, you also have the production of proteins C and S. These proteins are anticoagulant. That means they stop coagulation. Now, it turns out that the proteins C and S, they have a much shorter half-life. That means these get depleted much quicker compared to the procoagulant factors. So what do you think will happen? You can raise your hand if you want to answer. What do you think will happen when there is only procoagulant factors remaining in the blood? Yes, Muskan.
Bleeding time would increase.
Yes. So you'll have an increase thrombosis. Now, we said that, okay, there will be increased thrombosis. So now let's think about the exact name of this condition. We'll have warfarin-induced hypercoagulation. Correct? So you gave the patient warfarin and it caused hypercoagulation. Yeah, warfarin-induced skin necrosis. Sorry. So this thrombosis will eventually block blood vessels. And then if you block blood vessels, you will develop skin necrosis. Or not even skin necrosis, but any kind of necrosis. Because the blood isn't transported. And then the entire condition, that's called warfarin-induced skin necrosis. So now, any questions with this entire condition? This was the condition that we were talking about. Yes, I think someone raised their hand.
Can you please go up to the start of warfarin?
Here.
Thank you.
Yeah. So now that we've discussed all of these conditions, right? Yeah. So now that we've discussed all of these conditions, we also need to think about how can we prevent warfarin-induced skin necrosis. So what do you guys think? Yeah, Shafiq.
We can give a short period of heparin.
Yes, that is perfect. Now, let's assume that this is the timeline. We said that heparin, it works immediately. So let's say this is heparin. Heparin works immediately but has a short half-life. Warfarin has a delayed onset but has a longer half-life. So what you want to do is you want to initially start everyone on heparin. So you want to initially start everyone on heparin, and they'll be, they'll have anticoagulation during this period. And then once the heparin has taken its effect, then you can start these patients on warfarin. And then when warfarin completes the blockage of the V-cord, and then when warfarin has its effect, then you can remove the heparin. So, yes, Muskan.
So, doctor, you mean initially we will start with heparin, then we will give warfarin here, and when we will give warfarin, we should not give heparin.
Yeah, so it's not that you start the patients on both the medications together.
Mm-hmm.
It's like you give the heparin initially.
Mm-hmm.
After a while, like you stop the heparin, but heparin still has some of the life remaining, some of its half-life remaining. So in that period, you can start the patient on warfarin, and then warfarin, until it takes effect, heparin will wean off, and then the patient can be continued on warfarin.
Okay, thank you. I got it.
Yes.
Excuse me, doctor. Is the warfarin transmitted through the placenta?
Yes, that is actually a really good question. And the answer is yes. Warfarin is transmitted. Now, as so we've understood this condition for now. So we'll now talk about some of the things which make warfarin different from heparin. So warfarin does cross the placenta. It crosses the placenta. So if it crosses the placenta, obviously the type of effects that we'll see are teratogenic effects. Now these teratogenic effects, a lot of times, even like first aid, it doesn't really tell you what exactly these teratogenic effects are. But for NBME, if you ever see someone who has a bleeding disorder and then the child has skeletal abnormalities, if the child ever has skeletal abnormalities, you're immediately thinking of warfarin. Think about these skeletal abnormalities. Any kind of skeletal abnormalities. Yes. Oh, wait, I heard a hand raise. Yes, Gyanshani. Okay, maybe an accidental raise. Okay, that's all right. So you guys understood until this point?
Yeah, thank
Yes.
you. Amazing.
Okay.
I appreciate it.
Now, yes.
My question is, so we can't give warfarin during any trimesters, like first, second, and third. Is it contraindicated or
Now this is a rather difficult question. So, yeah, technically you should not give warfarin along any of the trimesters because the baby is constantly growing, and because warfarin teratogenically affects the skeletal system, so the skeletal system is constantly growing. So no.
Okay. So
Now,
what if a pregnant mother, who's having antiphospholipid syndrome? So what kind of medication you usually?
so now, I mean, the medications that we will talk about soon. So except for heparin and warfarin, we also have two other medications that we were about to talk. So we were going to talk about, right? We had factor 2A inhibitors and then factor 10 inhibitors. These ones. So these are the ones that you can still give to patients who have like a coagulation disorder. Yeah. Now, couple of things. We discussed heparin and we discussed warfarin. So now we need to differentiate between that. Differentiate between them. Let's write down heparin on one end. Let's write down warfarin on one end. Now, heparin, we said quick action. For warfarin, we said delayed action. Now, based on these actions, their half-life would be affected. So because it has a quick action, it has a short half-life. And because warfarin has a delayed onset, it has a higher half-life. So much longer acting. Now, one thing that we need to remember is that heparin, it will be monitored by the PTT or the APTT, and then warfarin will be monitored by the PT or the INR. Now, I have a very interesting question for you guys. We monitor heparin with APTT and then warfarin with PT or INR. So, what do you think? Is it only the PTT that heparin increases, or does it also increase the PT?
I think it's only PPT.
Okay.
Yeah, I think the
Sadly,
same.
yeah. So
Chris,
sadly,
Chris
that's
speaking.
yeah. So here there is one. Yeah, Shafiq.
Yeah, I think it will increase EBTT, but after a while it will increase BT. I read it in your word, but I don't know why.
Yes. So the idea, right, is that because it's uh, because it's decreasing the coagulation factors, so it will technically increase. So it will technically increase both the PTT and the PT, and that is the same for warfarin. It will actually increase the APT too. So it will increase both of these. It's just that the effect for heparin on APTT is much higher, and that is why we use this for monitoring. This is specifically for monitoring. It's not which one do they increase. It's which one can we monitor these medications by. And now this brings me to another point. We say that we need to monitor these medications. So if you're monitoring a medication, in what setting do you think the patient will be able to take these medications? Obviously, the patient will be able to take it in the hospital. But what about home? Will the patient be able to take these medications at home?
Yeah, it can be done an outpatient for the warfarin, but it will need close monitoring.
Yes.
Patient need to come 2 times a week.
Yes, you can do it at home, but it's too much hassle. You need a lot of monitoring. Maybe the patient lives like a couple of hours away from the hospital, so now the patient has to work a lot to actually get to the hospital. And there's certain conditions, not conditions, but certain restrictions that the patient has to adhere to. Patient needs to do blood draws every couple of days. That's too much work. So what we recently started doing, right? We started giving the patients two new medications. I mean, relatively new medications. One of them is a factor 2A inhibitor, and the other one is a direct factor 10A inhibitor. Now, both of these, they're under the classification of direct oral anticoagulant agents. So because they're oral, so it's much better for the patient to adhere to these medications. And another reason why these are so important and so good is because they do not require monitoring. They do not require monitoring. These are why we use these medications. Now, sadly, there is one thing that you need to remember, and that is the names. They have some rather weird names. So for the direct factor 2A inhibitors, these are.
I can help. I can help in that if you don't mind. Just
Oh,
just
no,
a small
that's
help.
all right. Oh, yeah,
Yeah.
sure.
Okay. Yeah. For X for thrombin inhibitor, which X factor 2. Usually it will come with tran, thromban. That's why I remember it. Tran, thromban. Yeah, it's in the end.
Okay,
Okay. And
that's actually a good idea.
for factor X, it will be X in the middle and like Rixo, ban, and there will be one is valent, something like that, which is also in X. Yeah, yeah. Thank you.
Oh, sorry,
This is the best
I got to
thank,
be.
thank you. Sorry.
Yeah, no, that's actually a really good way to remember these. I never thought about this myself. Yeah, but the medications, they are bivalirudin for 2A, and then you can remember the AN as we mentioned, which was or gatroban. So you have the AN here. You have dabigatran. So it has an AN at the end. And then all of these medications here with the XABN at the end. So you have rivaroxaban, riva, rivaroxaban, and there's one more, apixaban. Both of these, they're direct factor 10A inhibitors. Now, The effect, it's pretty much the same. Because these don't need monitoring, they can be given long term, they can be given at home, and there is not a lot you need to remember except for these two things. They can be given at home, they can be given for long term. However, there is one fact which the USMLE loves, and you'll usually see a very same question, which will be that it's about dabigatran, and it is that when you have a dabigatran toxicity, you can treat that with a medication called idarosizumab. This is a monoclonal antibody, and then it can help treat the toxicity which you can get from dabigatran. Additionally, let's say you have a toxicity with these exhibins. Yeah, if you have a toxicity with the factor 10 inhibitors, then the medication you can use would be called andexanet. Both of these are recombinant medications, and yes, this is just a fact that you need to remember. Andexanet for factor 10A inhibitor toxicity, and then idarosizumab for dabigatran toxicity. So any questions with the principles about factor 2A and factor 10A inhibitors? Perfect. Now there is, let me think. Oh yeah.
Excuse
There
me,
is,
kindly repeat the toxicity. If the dabigatran toxicity develop, what should we do?
oh, if someone develops a toxicity of dabigatran, you can give them this medication
Yes.
called idarosizumab. And if
Okay.
someone develops a toxicity with rivaroxaban or apixaban, you can give them andexanet.
Okay.
Now, it's not only toxicity from like factor 2A or factor 10A inhibitors. You can also have a toxicity with warfarin, or you could have a toxicity with heparin. Now, these toxicities, uh, there's a couple of things. So we'll talk about heparin because that's very simple. Whenever you have a toxicity of heparin, you give them protamine sulfate. You give them protamine sulfate. Now, how does protamine sulfate work? Protamine sulfate, it's actually like a very big molecule, and it has a binding site for heparin. So if this is the heparin molecule, protamine sulfate will directly bind the molecule with heparin, directly bind the molecule of heparin, so that the toxicity of heparin can be reduced. And now because it's direct binding, write it down. On the other hand, let's say we have a toxicity of warfarin. There's a couple of things we can do. 3 things to be precise. Let's say the patient has a toxicity, but it's not immediately a problem, and you want to naturally heal the patient. So you can do vitamin K. If the patient is not severe, so let's say the patient is in a mild, let's say the patient is in a mild condition. Now, on the other hand, let's say you have a patient who is in severe like toxicity, he's developed bleeding now. So you can give this patient something called as fresh frozen plasma or prothrombin complex, or like the cryoprecipitate. Now, for the USMLE, if you ever get a question with these two options together, I would say always pick the fresh frozen plasma. It's much better. But hopefully the USMLE won't give you both of them together. But if they do, always pick fresh frozen plasma. Yes, I
Doctor, what is the PCC again?
Oh, it's the so prothrombin complex like solution. Prothrombin complex concentrate.
Concentrate. Yes,
Yes,
doctor.
concentrate. Yeah. Let me actually write down the full forms. So you have fresh frozen plasma, and then you have prothrombin complex concentrate.
Doctor, can you please go back to those drugs, XA inhibitors and 2A inhibitors?
Yeah.
Uh,
So
Dr. Barnard.
oh yeah, these ones, right?
Yeah, the mechanism of action. Can you go back? Can you mechanism of action? Do they have separate mechanism of action, or they all have the same mechanism of action?
So for these, the recombinant medications. So what these medications will do is they'll just directly bind to the other. So let's say you have a rivaroxaban toxicity. Now, what andexanate will do is that it will just block the action of rivaroxaban. This will probably be a cellular action instead of direct binding. And the same with idarucizumab. They'll have cellular effects to prevent the toxicity. The one mechanism you do need to remember is with heparin and protamine sulfate. And this is basically a fusion. So correct me if I'm wrong, but I believe protamine sulfate is positively charged and heparin is negatively charged.
Okay.
So,
My question is actually on the not on their toxicity, on how the mechanism of action. You say they block XA and 2A. My question is, do they both block XA and 2A, or they work separately to different factors?
oh, yeah. So for factor 2A, and not even all of them, only for dabigatran, it only
Okay.
works with this medication. So this is the only medication which can reverse the toxicity, which is idarucizumab. If you
Okay.
have a factor 10A in toxicity, idarucizumab won't work. Instead, you will need to give them andexanate. And then andexanate won't work for dabigatran toxicity. These are two separate medications.
Okay.
Excuse me, Dr. Taha, could you please
Yeah.
explain the INR monitoring in while we are giving the patient warfarin? How we monitor it, and what's the role of INR?
So INR, or the international nationalized ratio, it's pretty much the same as PT. It's a monitoring unit, and if you talk specifically about INR, you need to remember that the value should be 2.5 to 3.5 if the patient has had a major surgery, and let's say it goes above 3.5, then you know that the patient is at an increased risk for bleeding because now he's anticoagulated or like hyper anticoagulated. And if it's less than 2.5, then it means it's subtherapeutic. That means you don't have any effect of warfarin right now.
Means if its level is getting increased, there will be these the warfarin is not acting its role properly.
Oh no, it means warfarin is actually like doing its role much better. So it
Okay.
is increasing the bleeding.
Yeah, can I add something if you don't mind?
Mm-hmm.
Yeah, usually INR is normally around 1. So when we give warfarin, we like it to reach 2.5. That means this is our target. Thank you.
Yeah. So our target is 2.5. That is correct. And then the accepted range would be around 2.5 to 3.5. So it is safe as long as it's still 3.5. But if it goes more than 3.5, that means you've given the patient more warfarin. If it's more than 3.5, means you've given the patient more warfarin, and that means you'll have increased bleeding. Now, if it's less, that means you've given the patient less warfarin. And now the patient won't really have any side effects, but then patient won't even have any effects.
Thank you. Thank you.
So,
Doctor, can you please recap the
sure.
warfarin toxicity?
So let me. Okay. So, but warfarin toxicity or the side effects?
Toxicity part.
Oh, the INR, right, that we talked about right now. So with the INR, it's just a way of evaluating like how much warfarin do you have. Standard value is 1.0. After a surgery, you want to keep the value between 2.5 to 3.5. Now, because this is a standardized like value, if you give more warfarin, so let's say you have increased warfarin, and the value goes more than 3.5, then you have increased risk for bleeding. Now, why do you have increased risk for bleeding? Because bleeding is a component of warfarin toxicity. On the other hand, if you give the patient less warfarin and the INR is less than 2.5, that means you've not given the patient enough warfarin and you have increased risk for thrombosis. And then what INR means, it's the international nationalized ratio. Yeah, I believe that's the full form for INR. Okay. So then, I believe those are all the topics or all the medications that we need to know for the coagulation cascade. There were 4 medications that we talked about. We talked about warfarin, we talked about heparin, we talked about factor 10A inhibitors and factor 2A inhibitors. So any questions in general, any questions that you guys might have?
Yeah, just a small clarification, Doc. Yeah, I think as regarding the use of what is heparin in pregnancy, first trimester, third trimester, after 37 weeks, something like that. Yeah, if you can, just
okay.
highlight it.
So,
thank you.
The idea, or like actually, this was a point that I was talking about. Now, there are certain teratogenic effects, right, which can be avoided after a certain trimester. So let's assume, let's assume this what's folate deficiency. Now, if you have folate deficiency after the so after the first trimester, the neural tube has already formed. So now you won't really have a neural tube defect because the neural tube is already formed. But with warfarin, because the teratogenic effect is on the skeleton, and because you have skeletal abnormalities, because with warfarin you have skeletal abnormalities, and because the skeleton constantly keeps on growing, even though it might be safe around third trimester, maybe even if it is safe, you should be very careful about prescribing warfarin because the skeleton keeps on growing until age 18. So you do not want to let the infant get in contact with warfarin because the skeleton is still growing. Now, with the example of folate deficiency here, the neural tube was already formed. So that's why there is no problems. But one of the skeletal symptoms or skeletal abnormalities is you might develop, it's called epiphyseal splitting. It means that the epiphysis, it kind of splinters and it splits a little bit. So now the epiphysis, it's still going to be there. It's still growing. So like, probably not the best idea to give warfarin to any pregnant mother, no matter the trimester.
Thank you, Doc. Thank you.
Yes. Okay. So then I'll let Dr.
Thank you,
Ahmad
Dr.
continue.
Taha.
So much.
Thank you, Doc. Thank you,
No
Doc.
problem. I hope you guys enjoyed. Yes.
Yes, thank you so much, Dr. Taha. And it was
And like
such a
we
great
enjoy
session listening you. So thank you so much for taking out your time and just teaching with all of your heart. Like as we do not have limitations of time, at least here. So thank you so much for putting so much effort. And I was just listening, and that was so great. So yes, anyone who have like feedbacks, please you can just give your feedbacks.
Awesome session, Doctor.
Thank you so much, Dr. Ramesh. Thank you so much.
so okay.
Dr. Taha, I think you should
It was
just take
very
rest.
wonderful.
Dr. Taha,
Sorry.
can you
Yes.
please take a screenshot for your right tab on the whiteboard and send it
Oh,
to us in the group?
okay. Let me. Okay, I don't think I
Yes,
will be
there are
able to
some.
Because
There are
see.
some, like
it's
amazing
so
notes.
blurred.
There are so amazing notes.
It's so blurred
No,
during the
no.
video. Yeah.
So
Yeah.
Dr.
Thank you.
Taha is going to share the screenshot. It would be like so clear, so amazing roadmaps and amazing session.
Okay.
So I think we
Oh,
have like
I have an idea. I'll share you the link. So I
Yes.
think that will be
perfect.
easier for.
Yes. Yes. Thank you so much.
Okay. Thank you.
Okay. So actually, the plan for the okay. So the plan now is that you guys just took a long sessions, 2 sessions. So let's have 15 minutes of break, right? And Dr. Taha would just take rest. I'll just continue the pathology section. We're going to finish that. But remember, you guys don't have to leave the session. Right after the section, Dr. Taha is also going to come. He's going to discuss some UWorld MCQ with you, right? Right after that, you by yourself are going to do some of your MCQs. And the task for today is then done. Go sleep and enjoy, right?
Perfect. Thanks for having me, guys. I will see you soon.
Question for Dr. Taha.
Yes, Doctor.
Oh, yeah, sure.
Thank
Dr.
you, Dr.
Taha,
Ahmad.
do we have toxicity for factor 2 and factor 10 inhibitors?
Do we have the?
Toxicity?
Yes. So we do have toxicity for factor 2 and factor 10. And if you develop the toxicity, then you need to use these medications to treat them, which is andexanet and then idarosizumab. So andexanet for factor 10, factor 10A toxicity, inhibitor toxicity, and then idarosizumab specifically for dabigatran, which is a factor 2A inhibitor.
Okay, I missed it. Thank you so much, doctor.
Yes. Thank you. I'll see you guys soon. Goodbye.
After how many minutes, guys?
15 minutes, guys. I'm just sitting
In
15 minutes.
15
right?
15 minutes.
Waiting for you guys. Don't leave the session, right? I'll be here. Those who want to like have a gossip, they can just have a 15 minutes of a gossip session. No worries. Why are you guys laughing? Okay, so let's have a interactive session. So are you guys just following the schedule here? Hello?
Trying to. It's better than the previous
Okay,
group,
thank you
doctor.
so much. Thank you so much. Like we are just working hard, and like actually, the pro like Dr. Taha there was like just given a specific time, and they were just like stressing Dr. Taha to just read the first chat and things. So here, as Dr. Taha is like open to speak, and everyone here is open to speak, right? So that was so amazing session, so impressive session by Dr. Taha.
Yeah,
And
thank you.
that
I,
was
I have to admit, I think
yes, Dr. Taha.
previously,
Yeah, actually, there
Yes.
was one thing that I'll tell you guys. I was told to complete all of endocrine physiology, like all of those 10-15 pages in 1 hour. That was the demands that I was given with. And they told me, like, you don't need to teach anything, just read it once. So I had
Yes,
no
that
choice.
was
I
so.
just had to do that. It was insane.
Like like Dr. Taha is so experienced tutor. So Dr. Taha, can you just please share your tutoring experience with our students?
Yeah. So I accidentally got into tutoring. I didn't think I'll get into tutoring, but I accidentally got in. And then I've been tutoring since 2 years now. I haven't tutored like a lot of students. I'll say I have tutored around 20 students because I do mostly one-on-one tutoring. And then a majority of them, I would say around 16 of them have passed the exams that they were tutoring for.
Perfect. That's so perfect. We just found Dr. Taha, and like we are so lucky to have him here, and contributing in this journey of USMLE. So it's like we are so grateful to have you, Dr. Taha. Thank you so much for giving your time.
Thanks for having me. Really appreciate
And
it.
soon, okay, let me just announce something. Soon we have registered our platform. As you guys know, that is next generation or next gen USMLE for all of the steps, and for even for the US clinical experience, and for the research opportunities. Let's soon me, Dr. Taha, Dr. Mahin, and some of our other crew members have decided to arrange a webinar for you guys, detailed webinar, and even we'll be also trying to reach you out personally, right? So you guys should be prepared for our messages, and okay, so please do note our official numbers, right? Like those are our official and permanent numbers. Like besides that, if someone is claiming to be like Dr. Taha, Dr. Mahin, Dr. Laiba, or like Dr. Hamza, so please don't believe that, right?
Could you share all the numbers?
Yes, so actually, you can just go in the group. You can just look the numbers. I'll just share them in the group as well. Just don't worry about that. But you should just trust the mentors. As I have already told you, now you guys are in like safe hands, and we are going to like um, do everything well, right? Okay, another thing which
Thank
I
you,
want to
Dr.
mention,
Ahmad.
like sufficient um, participants. So as I'm just telling you, we have registered our platform in US, and we just requested like many of the students were like interested in having online viewer, right? Yesterday, like Dr. Mahin showed you different features, like it's going to save your time. You have different functionalities within the within viewer, like you must know that how to use the keyboard, right? So there are certain commands in the keyboard which is only and only present in the official view world, right? So you should be like that. That's going to like save your time. You're also going to have a detailed webinar on that, right? So you guys should have your official view world, like because on your exam day, if you know the functionality, the key, how to use the keyboard, highlight option specifically. Highlight is like the I would say the best option, the notes option, right? So you can just save a lot of your time, because like we had a lot of students in the past. I just saw them, they like didn't use the official viewer, and like they were not able to pass their exam because of time management issues. And on the exam day, they were like facing problems with the functionalities, right? So it's the best time, as you guys are in the middle, and soon we are also going to announce how to use your UWorld. Like from now onwards, we are soon planning that UWorlds will be done in like a random mode in our revision session. So You should also keep that in mind that you guys are going to have a lot of webinars, a lot of guide. So just be prepared, right? So as we have registered, so I just requested the official UWorld team to get me some discount offers, right? So successfully and luckily they have accepted our request, and they just want the number of students who are interested in having official UWorld subscription. And if you have a lot of students, so obviously they are going to give us a discount code, and they just give us like an institutional discount code. So those who are interested in official UWorld, just please send their details. I have already shared in the group. Send your first name, and after that just send your year of graduation and the time span of UWorld in which you guys are interested. So we are going to make a spreadsheet of that, and we are going to email all of the details to UWorld, and right after that they will be just providing us with discount codes, right? So it's the best opportunity you guys can have in order to save some money in purchasing UWorld, right? Hello, are you guys getting me? Hello.
Yes, sir. Thank you. We can hear you.
Thank you, Doc. Yeah.
Yes, thank you so much. Yes, any
Yeah,
questions?
we are glad to have you, Doc. We are also glad for the mentors. Actually, we was having like hard. Last week was hard, but now everything is clear. And we are. I cannot wait to the boot camp because I missed the first lecture of the hematology, but I know I will catch it in the boot camp.
Yes, we are
And
going to do the camp.
we
Don't worry
hope
about
it will continue with you until we get our residency. Yeah, and I already share with my friends. They will contact you. New people would like to join, and
yes,
they
but
will be lucky if they join your session. Thank you, appreciate it, Doc.
thank you so much. Like this time, we have decided that once our this batch is completed, right after 2 weeks, then we are going to announce like the second batch of marathon, right? And this time the price is going to be so low. And another interesting thing which our team have decided, be Dr. Taha, Dr. Mahin, Dr. Laiba, and Hamza, in the next marathon. Okay, let me just mention it clearly. You guys should know that, right? We are going to recruit only 150 students, right? And we are going to conduct only 3 marathons per year. Okay, 100 students are going to be new students, right? And the remaining 50 students are going to be students from these 2 marathons who are just taking the classes, right? But we are going to select those 50 students based on their assessment scores, right? So we'll be taking time to time assessments, and we'll be like soon we are just arranging a learning environment that is LMS. We are just on our website. Our team is working on that. So we are going to like keep a track of your assessments, right? So we are going to keep track of that, and based on the assessment results, we are going to announce like lucky students 50 who will be like recruited for free in the next marathon, right? And for the new for the new students, we will also be taking an assessment, right? So based on that assessment, we are only going to recruit those individuals. Like in the next marathon, those who have like friends, so please you can just tell them to be a little bit prepared, because we do not want those who aren't participating in the classes, right? So we'll be working hard as well, and we need your time. You guys are also going to put efforts, right? So in this way, the system is going to work in future. And let me just give you another important news. Like I'm just leaking a lot of information about our new platform. Soon you guys are going to have a Discord server, yes, and that would be like really improved version, and so simple to use. Everyone can just log in there. You're going to have like a lot of features, and like I would say that it would be like so simple, even like simpler than WhatsApp, right? So we are just working on that, and we are soon deciding that the session will be just transitioning there for your reports and everything. Is it right? Hello?
Yes, sir. Thank you.
Thank you. Any questions? Yes, Dr. Peck.
Yeah, hi, Dr. Ahmad. This is thank you for telling us about the Discord. I have a question about the UWorld resources. So I've had this subscription for a while, and I had to stop using it because the previous platform, told us that they had UWorld, but then it turns out it was like just a basic version of it. So I do have the subscription, and I noticed that they released a few updates in the subscription, like flashcards and something called the USMLE library, UWorld library.
Yeah.
would it be beneficial for me to take for us to, I mean, would you suggest taking those as well? It's like an additional $50 or something for the
Okay.
flashcards
Okay.
and
Okay. Okay. So the thing is that the flashcards, you should definitely go for the flashcard, right? Flashcards are important, and for the library, you shouldn't go for that. So you should use Emboss library for that, right? Emboss, that is a free library available. So I won't suggest to use your library, right? I would suggest to use the free library Emboss. And for the flashcards, definitely you should go for that. Like there are like flashcards from UWorld, right? So you should
right.
just go for that.
Okay, thank you. And I have a compliment for Dr. Taha. I would say I had his classes before, and we used to think like, Dr. Taha's style is just reading from first aid, but we did not know that the management told him to do that. So I really loved his
No,
way of making
actually,
those
the
maps.
problem was that, yes. So the problem was like Dr. Taha was told to complete endocrinology, physiology within 1 hour. That's your task. And Dr. Taha was, struggling with that. And I knew that due to those issues, Dr. Taha somehow, he was just, his reputation was just compromising. So that's why, like, we felt to get apart from that platform. Okay, so with this, we have 1 minute remaining, and right after that, we are going to start our session. Okay.
Yeah, thank you. I have to say he's doing extremely good, and
Yes,
we love his way
Dr.
of teaching now.
Taha is an amazing
Thanks a lot.
tutor with amazing experience, and soon we'll be just announcing our website, and he is going to be our main tutor there for one-on-one consultation. So you can anytime just for these marathon student, marathon number 1 and 2, it's all for free for you guys. You can anytime reach us, but through a proper channel, right? Like you have to contact the management team, and you guys know the management team. You have Dr. Laiba and Dr. Hamza there, right? So as you know that Dr. Taha is also like working a lot. He is like also getting some interviews, so he might be busy sometime, right? So you should expect reply from the management team. Like everyone have to have their own role, right? So if you have problems with the task, Dr. Hamza, Dr. Laiba is responsible for that. For announcement, Dr. Hamza, Dr. Laiba is responsible for that, right? So this time we have a team, and we are working on a team as well. Like further, you guys are going to see improvement. Even for the free batches, we have arranged tutoring sessions, and this time everything is going to be really perfect. Thank you so much. Okay.
So I have a
Okay. So,
question.
please,
That's
yes,
new
please.
marathon. The new marathon you're talking about that we're going to pick 50 students from this group. Is this going to be marathon for step 1 or for step 2?
Sorry, I just didn't get you. Hello.
You said you're going to have another new marathon, and
We
you're
are
going to
going to.
pick to have another new marathon. New marathon.
Okay, new marathon. I just told you once we are done with this marathon, we will be like focusing 100% on this marathon. We won't announce another marathon once. Like first of all, you are going to complete that, right? This marathon. Once it's
Okay.
completed, then we'll be thinking of the next.
Okay.
So all of our focus is on this marathon, right? So our team isn't like thinking of some other marathon or marketing. So we are highly focused on these students to pass their exam, and that's all.
Okay.
Yes,
Excuse me,
and yes,
Doctor.
Dr. Yes, please.
Yeah, sorry. Like about my situation, my test already scheduled, and like I have about like 40 days, less than 40 days, and
Okay.
right now, like every day I'm pushing myself, and I'm just memorizing about like 50 questions,
Okay.
daily 50 questions, and
Okay.
I every day I try just to exam myself, and then a couple
Okay.
days ago
I got. You.
yeah.
Okay, doctor. Listen, doctor. One thing which you can do is just like text me. I'll just arrange a one-on-one session with our mentors. Those who are about to give their exam, like those who have booked their exam, just text me. We are going to arrange a one-on-one session for you guys, and we are going to give a personalized schedule and personalized plan to you. Right? So it would be quite better to have a one-on-one session, a complete entire one-on-one session on your situation. All of our mentors are going to like join that, and we are going to guide you. Is that right?
Okay, thank you so much, doctor.
Okay,
Okay.
okay,
So
doc. Yeah, for the others who don't book the exam, shall we wait until we see how we will do in the ME, or what's
okay.
your
So
advice?
for those, yes. So for those, we'll be arranging a general webinar, right? And we are just checking your progress. As you know, in the previous platform, I couldn't like I wasn't able to track your progress. So like from now, I'll be tracking your progress in the NBMEs. And besides that, as I've told you, we are going to arrange the webinars for all of you guys, right? But those who are close to their exam, those who have booked, we'll just arrange a one-on-one session for them. And as Dr. Setrov have like 40 days remaining, so we'll just make a personalized study schedule for him. Like we'll just schedule his day. So me, Dr. Taha, Dr. Maheen, and soon if the other mentors join, so we'll be just doing that. Okay. So thank you so much. This was all about. Okay, we are going to have a Q&A session in the end, but let's start our today's discussion, right? Okay. Hello. Okay, sir. Can you guys hear
Yes,
me?
yes, doctor.
Hello.
Go ahead. Yeah. We can hear you. Go ahead.
Hello.
Yes.
Okay, okay. Before starting the session, like, actually, I just upgraded my microphone. So, is there any difference in my voice?
Yes.
Much
Okay,
nicer.
thank you. So, okay, just give me. Okay, just give me 2 minutes, right?
Okay.
Okay. So, okay, first of all, let me just share my screen. Okay. Okay. So, let me just change the. Okay. Okay. Can you guys just see my screen?
Yes, we can.
Hello? Okay, perfect, right? So, okay. So the topic which we are going to discuss today is vitamin K deficiency, right? So Dr. Taha already took an amazing session of vitamin K deficiency, its associated factors. So I'm expecting you guys that you are going to tell me what's the role of vitamin K in activating like different factors. Yeah, so can you just tell me what's the role of vitamin K? How do it activate different factors? And what are the factors which are responsible or which like vitamin K basically activates? Yes. So please raise your hands, those who want to answer. Okay. So Dr. Shafiq, can you just please tell me quickly, as already Dr. Taha knows or told you so, like he just took an amazing session. So can you just tell me the factors?
It will be activation gamma carboxylation of the clotting factors.
Okay. Which clotting factor? 2, 7, 9, and
Yeah,
okay,
2, 7, 9, and
and
10.
protein C,
And if it's
protein
C and
C,
S. There is a
and S.
mnemonic, it's
Perfect.
1972.
Okay,
This is
1972. Perfect. Okay, so if you guys remember, Dr. Maheen was talking about
protein C and S and factor 5 laden, if you guys remember, right? So let me just give you a small concept. Let me just contribute something to that. Okay. So basically, protein C and S are normally our, like, we can say, a natural anticoagulant, right? So they basically play a role of natural anticoagulant, and they just like keep an eye whether if we have, for example, exaggerated activity of our procoagulants, which already Dr. Taha explained. So protein C and S is going to keep a check on that. How do it keep check? What's the mechanism of action? The mechanism of action is that protein C along with S, like S here, is going to act as a cofactor, right? Are you guys getting me?
Yeah.
Hello?
Yes, yes,
It's
yes.
going to
Yes,
it's
sir.
going to inhibit. Okay, it's going to inhibit, or it's going to like decrease the activity of which factor? Factor 5, right? Which factor? Factor 5 and hello?
Yeah, factor
Factor
5.
5 and which other factor? 5 and 8, right?
Yes.
Yeah, factor 8.
Okay, perfect. So, like as we discussed, that protein C and S are going to be like inhibiting, or they are going to decrease the activity of your factor 5, and in this way it would be acting as a like anticoagulants, right? But sometimes we can have a genetic deficiency of factor 5. We'll be discussing that in detail, right? But the idea is, due to that genetic like mutations or genetic problems, now what happens? Now your C cannot inhibit or cannot inactivate factor 5, right? For example, if something happens in the genes or genetics of your factor 5, and it would lead to like inactivation or inability of factor C to inhibit factor 5. If we have inability to inhibit factor 5, so can I say that we'll be having a state in which we are going to see more coagulation? Can I say that? We are going to have hypercoagulable state.
Yes, sir.
Is that right? So that's basically the idea of factor 5 laden mutation, which we'll be discussing, right? And that was the thing
Can you
which
please say?
actually, can you, Dr. Hazira, can you just please fix your mic? Okay, no problem. So protein C and protein S and 2, 7, 9, 10, you already know that vitamin K basically activates them, they gamma carboxylates them. Once they are gamma carboxylated, they are converted into their active form. They are procoagulants, which Dr. Taha just told us, and the C and S are anticoagulants. So how do it perform its activity of anticoagulation? It would inhibit the activity of factor 5 and factor 8. Yesterday we already discussed factor 5 and factor 8. If we are inhibiting the activity, okay, normally, right, C and S inhibits the activity of factor 5 and 8. So in this way, basically we are avoiding hypercoagulable states. But what if, due to certain mutations, factor 5 genome or genetics are changed? So now what would happen? Factor C or protein C and S cannot inactivate factor 5. If we cannot inactivate factor 5 due to genetic deficiency or genetic mutation, so what happens as a result of that? This individual is going to end in hypercoagulable state. Is that right? Hello?
Yes, doctor.
Yes.
Yeah.
Okay, perfect, right? So we already discussed that. We discussed the deficiency. So can you just tell me that in which case or in which scenarios and in which pathologies or in which condition do we have deficiency of vitamin K? We already discussed that vitamin K is important for activation of all of these factors, right? Dr. Taha already told us. So can you just tell me that how can we have deficiency of vitamin K?
In
What
the case
condition?
of cystic
Liver
fibrosis,
cirrhosis.
Okay, perfect. So
In
today
liver
in the UWorld
cirrhosis.
MCQ, okay, perfect. So in the UWorld MCQ, we discussed that one of the condition can be like your pancreatic insufficiency due to cystic fibrosis. Like we have a thick mucus plugs which can just, block the ducts of your pancreas and it cannot release its enzyme. And as a result of that, what happens? If the pancreas cannot release enzyme, what's the function of that? You cannot reabsorb fat. If you cannot reabsorb fat, it means you are going to have deficiency of the vitamin which go along with the fats. Which vitamin? A, D, E, K, right? Perfect. Now you guys just got the association that how do cystic fibrosis lead to vitamin K deficiency? Like you can just relate it, and K again is causing problems with factor 1, like here 2, 7, 9, and 10, right? And protein C and S, right? Okay. Another thing, you guys already know that like in our GI, basically the bacteria in our GI or GI colonization bacteria, they also contribute in synthesis of vitamin K. We already know that, right? So for example, if let's suppose if I have a newborn, right? So we already know that the newborn, basically all of the food and all of the content is provided by the mother, like, or in other words, I can say his GI functionality is at his low. You have least GI functionality. So can I say that in newborns we'll be having less bacteria in his colon, which are responsible for vitamin K synthesis? So can I say that newborns are prone to have vitamin K deficiency? Can I say that?
Yes, sir.
Perfect. So
Yes. Yes.
newborns can have vitamin K deficiency. Why? Due to less GI colonization. Is that right? Okay. And in turn, this deficiency can lead to, you guys already know, yes, decrease or inactivated or less functioning of these factors which we have mentioned. 2, 7, 9, 10, as Dr. Shafiq told us, 19, okay, 72, right? And protein C and protein S. Okay, what else can lead to vitamin K deficiency? The idea is really clear. We know that these GI bacteria basically contribute in formation of vitamin K. For example, if I'm just giving an individual a lot of antibiotics and I'm just killing that bacteria, so killing of those bacteria or killing of those colonies of bacteria, again, can I say it would lead to vitamin K deficiency, even in an adult, right?
Yes, sir.
Well,
Yes, doc.
perfect. So if we are just administering a lot of antibiotics, it can lead to deficiency of vitamin K. Okay, another thing which we discussed, fat soluble vitamins, as just doctor told us. Let me just write that down as well. Pancreatic insufficiency can also lead to vitamin K deficiency. Is that right? Hello?
Yes, sir.
Yes, okay.
Yes, doc.
Okay.
Yes, doc.
Okay, perfect. Okay, other causes of abnormal secondary hemostasis. Okay, one we discussed that if we have vitamin K deficiency, right? We already know that these coagulation factors are basically made by your liver. So for example, if you have liver failure, cirrhosis, so it means that we won't be having enough coagulation factor. It can also lead to abnormal secondary hemostasis, right? Okay, so the next topic which we are going to discuss is disseminated intravascular coagulation. Like I would say the highest yield topic, you're going to have a ton of MCQs today, the UL discussion with Dr. Taha, believe me, right? So let's do that in a little bit detail, right? So what is DIC? Basically, it stands for disseminated intravascular coagulation. So let me just tell you the main idea of DIC, right? So what happens in DIC, it's basically a problem of coagulation factor, or like it's basically a problem of both your primary and secondary homeostasis, right? Okay, so okay, we discussed what happens in primary homeostasis. We discussed it's basically going to deal with function of your platelets. We discussed that, right? Hello?
Yeah.
Yes, doc.
Yes, doctor.
And secondary homeostasis is going to deal with the,
Clotting
like
factors.
the clotting factors, perfect, which we discussed, extrinsic and intrinsic pathway. So what happened in DIC? We have exaggerated activation of both your primary and secondary homeostasis. Like both the platelets are going to be activated or exaggeratedly activated, and along with that, the secondary homeostasis, that is the clotting factors, both of these are going to be exaggeratedly activated, like both platelets and clotting factor. So what would happen as a result of that if we have exaggerated activation of platelets and clotting factors? So can I say that we are going to see a lot of clots everywhere inside our body? And these clots would basically consist of both platelets and clotting factors. Can I say that?
Yes, doc.
Yes.
So that's the main idea. So now a question arises that what process leads to activation or exaggerated activation of your platelets and clotting factor, right? So it should be a question which should arise in your head, right? It's a common question. Okay, so before that, let's discuss some lab findings, right? So if I have a lot of platelets being aggregating at different sides of your blood vessels, or if I have exaggerated activation of secondary hemostasis or the clotting factor. So let's discuss some lab findings, right? What lab findings are basically associated with DIC? As Dr. Mahin told you, the lab findings are going to be the most important and highest yield things which you guys are going to focus on, right? So can you guys just tell me what will happen to the platelets count if I'm consuming a lot of
Will be
platelets?
low.
Low
Perfect. So
platelets.
platelets would be low. If the platelets are low, how do we look for the activity of platelets? We go for the bleeding time, right?
Yes.
What would happen to the bleeding time? Increased. Perfect. Okay. If we have exaggerated activation of our like coagulation pathway, both like extrinsic or intrinsic, both pathways. So what do you think? Well, like how to assess the activity of those pathways? We discussed. We are going to look for PT and
PT, APTT.
PPT. Perfect. So what would happen? As a result,
Both prolonged.
both would be prolonged. Perfect. Okay, what's the main idea of PT and PTT and secondary homeostasis? That is, the main idea of this pathway is to activate your fibrin, right? Hello?
Yes, right.
Yes, doc.
Okay, fibrin basically comes from fibrinogen, right?
Yep.
Yes.
So can I say that fibrinogen is going to be so low?
Yes.
Because all of it is going to be consumed, right?
Yes.
An important thing. Can I say that it would lead to MAHA? We discussed what is MAHA. You know, a meshwork of platelets or a meshwork of a lot of clotting factors. So can it cause MAHA if you have exaggerated activation everywhere inside your body? Can it
Yes.
cause MAHA? Okay, what was the full name of MAHA? Microangiopathic hemolytic anemia, as the name indicates. Microangiopathic, any pathology of angio, that is like small blood vessels which lead to hemolysis. How do it lead to hemolysis? If the red blood cells are passing to these meshwork, they are going to tear them into pieces and they are going to convert them into characteristic kind of cells, which are basically known as helmet cells or schistocytes. Is that right? Hello?
Yes, sir. Yes,
Okay.
sir.
So you should just keep each and everything in your mind, right? So you're going to have a bunch of, I would say, a lot of MCQs on DIC, right? So believe me, if you just get today's topic, so it would be like a piece of cake for you guys, right? Don't worry about that. And if you have like some like aspects of DIC remaining, so Dr. Taha is going to help you out with that in your UWorld session, which is going to be held right after this session by Dr. Taha. Okay. Another point. So if you have like a lot of fibrin, right? A lot of fibrin or exaggerated fibrin depositing in different like various parts of your blood vessels. So can I say that as a result of that, what happens? We also have like a mechanism inside your body which do not allow the fibrin or exaggerated activity of fibrin. Or in other words, I can say in order to look for activity of fibrin, we have a mechanism inside our body, right? What's that? Can you just tell me? Hello?
Plasmin or sham is going to be
Plasmin, perfect,
plasmin.
plasmin. So what plasmin do? We have plasminogen, right? So plasminogen is going to be converted into plasmin. And what's the goal of plasmin? Plasmin is going to cleave if we have exaggerated fibrin deposition, right? So in this case, as we are discussing that we have exaggerated activity of our pathways, extrinsic and intrinsic pathway as well. So we are going to have a lot of fibrin, right? So what happens? As a result of that, the plasmin is going to be more because your body would just, won't allow a lot of fibrin to be deposited there. So what would happen? This plasmin is basically going to break it down into certain products. And basically, what are the name of those products?
D-dimer.
D-dimers, perfect. D-dimers, right? So can I say that in the lab findings, okay, what would be the concentration of D-dimers in case of DIC? What do you think?
Increased.
Elevated.
Sorry?
Increased. D-dimer levels will be increased because of
Perfect.
degradation of the fibrin.
Okay, that's perfect, right? So this was all about lab findings. Now a question arises that why do we have this condition, right? What causes this condition to occur? Well, it should be a question that you should be asking, right? In your mind. So what do you think? What can lead to like this, like this pathology? What are the causes? What do you guys think?
Infection,
Okay, please raise your
obstetric
hands.
complication.
Okay, perfect. Please raise your hands. Okay, so let me just pick someone. Okay, raise your hands. Dr. Victor. Yes, Dr. Victor. What do you think? So just tell me one of cause of this pathology. What led to overactivation or exaggerated activation of both of your platelets and coagulation factors?
Something related to it.
Sorry?
Sorry, I didn't get the question.
Okay, the question is that here in this case in DIC, what happened? We discussed that we have exaggerated activation of both of your primary and secondary homeostasis. So what do you think? Can you just tell me a single cause which you know that due to that reason we have like this condition? What do you think?
Sepsis.
Like one of the sepsis, perfect. So what's the idea of sepsis? We already know that. For example, if someone is infected with gram-negative bacteria, so basically they produces endotoxins, right? Which is like present in their membrane. You guys know that lipopolysaccharide membrane can act as endotoxins once they are broken down into pieces, right? So how do sepsis lead to this condition? The idea is really simple. We have a lot of endotoxin. They are toxic to your endothelium. They are going to destroy or damage your endothelium. Can I say that? Hello?
Yes, doctor.
Okay,
Yes,
once
doctor.
endothelium is damaged, we already know damage lead to activation of both of these pathways, right? Your primary and secondary homeostasis. So if you have a lot of damage, you are going to see a lot of primary and secondary hemostasis. Is that right? So can I say that in this way, sepsis can lead to DIC, consumptive coagulopathy. You have a UWorld MCQ on that. On sepsis, they're going to give you an MCQ. Today, you guys are going to do that. Does that make sense?
Can you repeat what is
Can you
primary and
please
secondary?
repeat?
Okay, so the idea of sepsis is that you know that in the sepsis, you have like, for example, if someone is having infection with gram-negative bacteria, so what happens? Gram-negative bacteria basically have endotoxins, right? And endotoxins from these bacteria, they can, you know, like activate a lot of cytokines, right? They can just activate your inflammatory pathways, right? And those inflammatory cytokines can induce inflammation. They can damage the blood vessels. Is that right? And damage of blood vessels, you know, they call these pathways to please save me, right? Is that right? So if we have a lot of bacterial overload, a lot of sepsis, it means we have a lot of damage. And if you have a lot of damage, you have exaggerated activity of your platelets plus your clotting factors. Or in other words, both primary and secondary homeostasis are going to come into play, which is going to lead to this condition DIC. Is that right? Hello?
That's right.
Okay, perfect. So can anyone, okay, please raise your hand. Do anyone know another cause of DIC? Please raise your hands. Yes, Dr.
Yeah.
Muskan, what do you think?
In eclamptic patients, yeah.
Okay. So yes, that could also be a cause, right? So like we do also, okay, let me just discuss one of another UWorld MCQ, right? So any obstetric complication,
Yes.
you're going to see a UWorld
Eclampsia,
MCQ on that.
eclampsia patients. Yeah.
Yes, eclampsia, perfect, right? So what happens that, for example, if you know, if you have a baby and we're just delivering that, so what happens sometimes like that? Okay, we discussed different pathways, right? We discussed like tissue thromboplastin, which can be, you know, like related with tissue factor, right? So if we have like amniotic fluid which comes into your blood, it can also cause DIC, right?
Yeah.
Why?
Not
Because
embolism, yeah.
we can have embolism of amniotic fluid as well, but amniotic fluid itself can cause this pathology. Why? Because we discussed that we have tissue thromboplastin, right, in your amniotic fluid as well, right? So tissue thromboplastin is simple, you can say it's a tissue factor, right? And tissue factor, we know it activates your extrinsic pathway. We discussed that yesterday, right? So it can exaggeratedly activate like both your platelets, primary homeostasis and secondary homeostasis, which can lead to DIC, right? So let's discuss some other causes. For example, snake bite can also do that, right? They also have like the tissue factor or thromboplastin. Another thing which we already discussed, and I want to assess you guys on that, right? So I'm going to ask you a question. Did you guys remember a syndrome which was Trazul syndrome? We discussed it like in the various topics in various modules. In cardiovascular section, we discussed Trazul syndrome. And the endocrinology, once we were doing adenocarcinoma, we discussed Trazul syndrome. So can anyone just tell me
Yes,
what is Tourette
doctor.
syndrome?
It's migratory phlebitis.
Okay, please raise your hands. Please raise your hand before answering. Okay, Dr. Ramesh, what do you think? What is Tourette syndrome? Hello, Dr. Ramesh.
Yeah. So it is seen in hypocalcemia.
Okay. Okay, that was a true sign.
Okay. Trousseau syndrome. It's migratory thrombophlebitis. That is Trousseau syndrome.
Perfect. We discussed that in basically it's associated with adenocarcinoma, and basically whenever we have adenocarcinoma basically leads thromboplastin. We discussed, right? That's same as that of tissue factor, right? And
Yes.
I just told you we are going to have a hypercoagulable state, right? Hello?
Yes,
So
doctor.
Yes, sir.
okay, we discussed that in adenocarcinoma, it's basically like Artazu syndrome, like you are going to have a triad in which we can say like migratory thrombophlebitis. We are going to have a hypercoagulable state, which is associated with adenocarcinoma, right? So adenocarcinoma, the mucin basically activates a coagulation, right? It would release a thromboplastin, which would activate all of your pathways, and it can also lead to DIC. I think now that concept and that point is clear, right? So we already discussed it in 3 systems, right? In cardiovascular, we discussed that, right? And second in adenocarcinoma, and it's the third. And right after this topic, I don't think we will be discussing that again, right? So I think that concept of Tourette syndrome is clear. So let's discuss our next disorders or our next topic, which is thrombosis, right? So like now the topics are going to be really easy, so I expect you guys to answer that. Like we have like 3 topics remaining for today's lecture, that is thrombosis. After thrombosis we have like embolism, and in the end we have yes, these 2 topics, by the way, right? So there are some subtopics and some mechanism involved, right? So let's just keep it a little bit interactive. So can you just tell me what is a thrombus?
Doctor, before we move ahead, I have a question.
Yes, please.
So you said that in abrupt placental rupture, it's the tissue thromboplastin. So the tissue thromboplastin will directly activate this pathway.
Okay, so
Is that what you said?
okay, so the idea of DIC is that you should just know the idea, right? If you have exaggerated activation of like platelets, the clotting factor, so what happens that whenever we have like amniotic fluid, for example, if you are just delivering a baby and amniotic fluid, it enters the mother blood, right? So the amniotic fluid itself have tissue thromboplastin, right? So that amniotic fluid can cause DIC. What else can cause DIC? We are going to discuss that. If you guys remember, do you guys know what are all roads? Hello? Okay, so in the white blood, yes, we are going to discuss that. In the white blood cells module, which is going to be right after the red blood cells module. Remember, I'm going to discuss one of another cause of DIC, but it's not a suitable place to discuss that. So we'll be integrating different concepts, right? So this was all about DIC. So let's come to other topic, that is thrombosis, right? So can anyone just tell me what is thrombosis?
Yeah,
What is thrombosis?
can I say?
Yes, please, definitely.
Yeah, thrombosis is a blood clot that form in the blood vessels, blocking the blood flow.
Okay, perfect. We have blood clot, right?
Yeah.
Okay. So basically, for example, we can have blood clots like anywhere inside our vessel. Like it can be in the veins or it can be in the arteries as well, right? So
Yeah.
the common one which we keep on discussing again and again is DVT, right? Deep vein thrombosis, which is going to cause a lot of problems, right? So this is the best time to discuss DVT or deep vein thrombus or deep vein thrombosis in a little bit detail. What are the characteristic features of DVT? For example, if you have a popliteal vein, right, there we have a thrombus. We discuss what is a thrombus. Thrombus is basically, we discuss a blood clot, right? But it's not exactly a blood clot. In order to declare something a thrombus, it should be satisfying certain criteria, certain characteristics. Do you get me? It's not
Yes.
simply a blood clot,
Yes.
right? So what are the criteria or what are the characteristic features of a thrombus? Basically, we have 2 of them, right? 1 and 2. And you're going to see you got MCQ on that today, right? Okay. The first one is, okay, let me just give you a clue. You guys are going to explain that. Lines of Zane. And the second one, it should be attached to the blood vessel. Like you are going to see it attached to your blood vessel. So once a blood clot is having these two features, then you are going to declare it as deep vein thrombus. Did you guys get me?
Yes.
Okay. So can anyone just tell me what is line of Zahn? Okay, please raise your hands. Yes, Dr. Muskan, what do you think?
Doctor, I think it is like a alternate pattern in which we see the platelets with and RBCs. Alternate patterns. Platelets, RBCs. Platelets, RBCs. I think so.
Okay, perfect, perfect. So we are okay. So we have an alternative or alternate layer of certain things, right? What certain things we are going to have platelets, right? Okay, let me just draw down platelets with yellow color, right? And on the platelets or fibrin, you can have platelets or fibrin, right? And upon that, you are going to have red blood cell. You're going to have platelets and red blood cells that are going to be called as Zahn lines, right? And the second characteristic feature, they should be attached to the blood vessel, right? Then you are going to declare it as deep, like a thrombus, deep vein thrombus, right? Okay. So can you just tell me that what causes thrombosis? What are the factors which causes thrombosis? So for that, we have a triad, which is known as Virchow triad, right? So in order to get thrombosis or in order to get thrombus, there are three states which are important, okay, which aren't important by the way, like which are, which aren't important for a normal individual. But in order to like get thrombus, three things are going to be seen in an individual, right? Which is basically denoted by Virchow triad, right? Hello? Are you
Yes,
guys getting
doctor.
me? Okay,
Yes.
what three things? First of all,
That's
endothelial damage, right? Endothelial damage or a hypercoagulable state. And yes, what other?
stasis.
Stasis, perfect. Stasis. So endothelial damage, we discussed that a lot of things can cause endothelial damage. Hypercoagulable state, we already know that, for example, certain drugs, oral contraceptive can cause hypercoagulable state. With the stasis, we know stasis can also cause hypercoagulable state. Okay, let me just revise something. How we discussed that stasis can cause hypercoagulable state, it can cause thrombus. We already discussed one of its example. Let me just give you an overview, a UWorld MCQ, atrial fibrillation. We discussed that, right? And in the atrial fibrillation, basically we have a thrombus specifically in a sac-like region. You have a UWorld MCQ on that. What's the name of this sac region? That's like my question. Please raise your hands.
Appendage.
Okay, the atrial appendages, right? Atrial appendages. So the idea is that, for example, in atrial fibrillation, we know that your atria isn't able to contract, right? So we are going to see stasis, right? If you are going to see stasis, so all of your clotting factors are going to become concentrated. And once they are concentrated, they can activate your coagulation pathway and it can lead to thrombosis or thrombus formation. Is that right? So in the UWorld, you can also have that we see like we have an individual, he was like traveling along, he was sitting on his seat, for example, in a train or in a jet, you can say, right? So, and once he just, reach his destination, right after that, like he can have thrombus, pulmonary embolism, which is going to be our next topic, right? So stresses should be taken into consideration, right? You have another UWorld MCQ, hypercoagulable state. For example, we know what causes hypercoagulable state. We discuss using of oral contraceptive pills can cause that, right? We have a lot of reasons for that, right? Endothelial damage. We'll be discussing how can we have endothelial damage. Is that right? Hello? Okay.
Yes, doctor, right.
Yes,
So let's
sir.
Yes, sir.
discuss
Yes.
each one. Okay. So let's discuss each factor of Virchow triad in a little bit detail, right? So, okay, before discussing that, let's like it's a part of a topic. We also have some Virchow nodes, Virchow lymph nodes. Where are they present? Hello?
Clavicular. The left.
Supraclavicular region. Left
Supraclavicular
Supraclavicular.
region, yeah.
Perfect, perfect. That's supraclavicular region. And we have which kind of cancer do metastasize to that region? Your UWorld MCQ.
Gastric carcinoma.
Gastric.
Gastric carcinoma. Perfect. That's perfect. Okay, so with this question, or like which was apart from this topic, let's have 5 minutes of break. Is that right? Hello?
Yes, sir. Thanks.
You guys can just enjoy.
Yes, Jack.
You guys can just enjoy, just chill out. We'll be just covering two of our topics, and with that, the platelets module is entirely finished, along with pharmacology. And Dr. Taha is going to continue the session of UWorld. You guys are only left with 19 MCQs, 10 of them Dr. Taha is going to help you, and 9 of them are for your practice, right? So that's the entire schedule for today, and then you close your books and sleep, right? Okay, so let's have 5 minutes of break. Hello? You guys hear me? Hello?
Yes, doctor.
Hello? Can you? Okay, that's perfect, right? Can you guys just see my screen?
Yes.
Okay, perfect. So okay, we already discussed that how do stasis causes like thrombosis, right? So let's discuss our next factor of cotriard, that is endothelial damage. So in which situation or question arises, in which situation we can have endothelial damage, right? Endothelial damage. Okay. So we can have endothelial damage like due to a lot of causes, and there are like several mechanisms which lead to which causes anti thrombosis. Like normally, our body do have some mechanism in order to avoid thrombus formation. So for that, we should know some of the mechanism which our body uses in order to avoid thrombus, right? Because thrombus isn't good for us. We do not need thrombus to be there in your blood vessel. So there are some mechanism which our body have. So can anyone just tell me that which mechanism can we have? Like it's simple, clear, right? Yes. Can anyone just tell me? Please raise your hand. What mechanism do we have, or what protective mechanism do we have to avoid thrombus formation? Yes. Please raise your hand. Anyone? Dr. Muskan. What do you think? Hello.
Doctor, can you hear me?
Are you guys able to? Yes, I can hear you. Yes.
So, doctor, the first, I think it is like we talked about plasminogen, so tissue plasmin activator, tissue plasminogen activator, I guess, because when there will be more plasma, so there will be more degradation of fibrin. So I think it can help.
Okay. So one of the mechanism which we discussed that basically we discussed that thrombus can be cleaved by one of a mechanism, that is plasmin. Another mechanism like the endothelium itself, we discussed that we have endothelium, right? We discussed a lot of times in atherosclerosis. Yesterday, we discussed each and every day that this endothelium basically do not allow the subendothelial collagen, right? So whenever we have exposure of subendothelial collagen, then we discuss we are going to have activation of primary or secondary homeostasis. We discussed that, right? So can I say that endothelium itself provide a physical barrier in order to cover your subendothelial collagen, and in this way it is avoiding the formation of thrombus. Can I say that?
Yes.
Okay, so endothelium itself. So can I say that if this physical barrier is disrupted, like for example, if you have damage, so can I say that this damage can lead to exposure of subendothelial collagen, which can lead to thrombosis, right? So we are basically talking about the protective mechanism. Yes, so the protective mechanism is endothelium itself. Another thing Dr. Taha today has discussed, what is happening basically is like an antithrombin 3 molecule which avoid the formation of thrombus. So normally we have heparin-like molecules in our endothelium, right? So heparin-like molecules are also present and they are basically avoid the formation of thrombus, right? So these are some protective mechanism. One of the protective mechanism which Dr. Told us, that is the activation of plasmin. And another mechanism you already told or discussed, that is natural anticoagulants. Yes, protein C and protein S.
Yes.
Right? We discussed that. Okay, perfect. Okay, another thing which you guys should know, like it's a must pathway, you guys should know, because the same pathway we are going to discuss tomorrow in red blood cells module, in the hematology module, right? So this was platelets module. Today is going to, it's like almost ended. Tomorrow we are going to start hematology module, that's red blood cells module, and I'll be discussing this pathway again here, right? So that's simple, right? Okay, we know that we have DNA, right? DNA is basically present in the nucleus. We need certain building blocks for DNA, right? And one of that is folic acid. Like we need folic acid for the formation of your DNA, right? It's a DNA precursor. Can I say that?
Yes.
Yes, folic acid or folate basically helps in formation of DNA, right?
Yes, with
Formation.
amino acids.
Oh, perfect. Yes, of DNA, or simply I can say. But normally the folate keeps on circulating inside your blood. It's not like simply folic acid, right? So it keeps on circulating as tetra hydrofolate Hello? With a methyl group attached. Hello? Can you guys hear me?
Yes.
Okay. Okay.
Can
So,
you please repeat it?
yes. Okay. So basically, we need folic acid in order to, like, folic acid simply is a precursor of DNA, right? If you need the formation of DNA, if you need DNA to be formed, you need folic acid or folate. Is that right? But normally, folic acid basically is present inside your blood in a form of tetrahydrofolate binded to methyl group. Is that right?
Yes, sir.
Okay, but in order for this folate or tetrahydrofolate to participate in the formation of DNA, it have to leave this group. It have to give this group to another thing, right? Which thing? That is vitamin B12. Are you guys able to understand?
Yes, sir.
Yes, sir.
Okay, perfect. So, in order for the tetrahydrofolate to participate in DNA synthesis, it have to give this methyl group to B12. So what happens now? Methyl is going to be attached to B12, and now tetrahydrofolate can go. It can participate in formation of DNA. Okay, we also need B12, right, for the formation
Yes,
of.
sir.
Okay, so for example, if we have like a lake of B12, or if we need B12 for certain things, right? Okay, what's the function of B12? Hello, hello.
Bit of acts as a
It will
choker.
it help methylation of the myelin sheath in the neurons.
Okay, okay, perfect. So, for example, if I need B12 there, like as Dr. Shafiq told us, for methylation of the okay, myelination or methylation. Yes, what's that, Dr. Shafiq?
Myelin sheath to help
Okay,
the myelin sheath. Yeah.
formation of myelin sheath, right? So it means that now again it have to leave the methyl group, and it have to transfer this group to some other thing, right? And what's that other thing? It would just transfer this group to, yes,
Homocysteine.
homocysteine. And homocysteine is going to be then converted. Once it just get methyl group, it's going to be converted into methionine, right? But remember, homocysteine itself is toxic to your endothelium, right? So it's basically
Yes, sir.
methionine, and methionine is not toxic. It's like not toxic. It do not lead to any toxicity of your blood vessels, right? So let me just repeat
Doctor,
this pathway again.
just I
Okay.
have one question. So you said that it will transfer the methyl group to homocysteine, yes? Then
Yes.
this homocysteine will transfer it to what?
Okay. Okay. Once it transfer methyl to homocysteine, okay, we need that. Why? Because homocysteine itself is toxic to endothelium. Once homocysteine receive this methyl, it's going to be converted into methionine, which is non-toxic, and we need that, right? Okay. Okay. I'm just discussing this again. Remember, in red blood cells module, we will be discussing this pathway again in macrocytic anemia. Why do we have macrocytic anemia? Again, I'll be discussing the same pathway. So just please, I'm just spending some time on it, right? So we discussed that folic acid or folate is like a precursor of your DNA. So normally in the blood vessel, in the blood, it is found as tetrahydrofolate binded with methyl group. For example, if there is need of tetrahydrofolate for DNA synthesis, so what happened? It would just transfer its methyl group to. Can you just please fix your mic? Whose mic is that? Doctor. Okay, thank you. Okay, so we were discussing that if we need tetrahydrofolate, it have to give its methyl group to vitamin B12. For example, if we need vitamin B12, as doctor told us in myelination, right? So again, it have to give methyl group to homocysteine. Why? Because that's an important phenomenon. Because homocysteine, we discussed, it's toxic to your endothelium, right? So we need that in order for the homocysteine to be converted into methionine, and which is non-toxic, right? So for example, if we have like folate deficiency, if we have B12 deficiency, let's suppose if we have folate deficiency, it means now we have less folate. So folate cannot give methyl group to B12, right? And in turn, B12 cannot go give this methyl group to homocysteine. So can I say if we have both folate deficiency or vitamin B12 deficiency, it's going to lead to accumulation of homocysteine? Can I say that?
Yes, sir.
Perfect. And we discussed if we have a lot of homocysteine, it would lead to damage of your endothelium. Can I say that?
Yes,
Yes,
sir.
sir.
It's
Yes,
gonna
and
increase
this
the
yes, and this was damage to your endothelium was one of the triad which we were seeing in virtual triad, right? One of the factor. Is it right?
right, sir.
Okay, perfect. Okay, so let's discuss some hypercoagulable states, and with that, right after that, we're going to discuss a small topic that is embolism, and then we are going to then Dr. Taha is going to proceed with the UWorld discussion, right? So you guys are going to tell me like some of the some of the conditions in which we are going to see hypercoagulable states. Yes.
Protein C and S deficiency.
Okay, perfect. If we have less protein C and S, it means okay. We discussed protein C and S. Dr. Taha told us that itself are anticoagulants, right? How
Yes,
it would
right.
it would inhibit the activity of factor 5 and factor 8, right? And in this way, that would cause anticoagulation. Is that right?
Yes.
Yes,
Okay.
sir.
We discuss a condition, for example, if you have genetic mutation in factor 5, right? We have genetic mutation of our factor 5. What happens as a result of that? Now your protein C and S cannot inactivate it, right? That was normally seen, right? That was the normal mechanism of action of your protein C and S. So can I say that this genetic deficiency of factor 5, which is also known as factor 5 Leiden, yes, what's the name?
Factor 5 Leiden.
Yeah.
Factor 5 Leiden mutation, right? Simply. So again, can I say that this factor 5 Leiden mutation can lead to hypercoagulable state? Hello?
Yes, sir.
Yes, sir.
Correct.
Okay, okay, perfect. Some other causes? Anyone?
Cystinuria, right?
Cystinuria.
High
Malignancies.
Okay, malignancy can also do that. Okay, so let me for example, if we have antithrombin 3 deficiency, we discuss antithrombin 3. Normally, we have these molecules which act like heparin, right? They are heparin molecule. So if we have deficiency of those molecules, we can have a hypercoagulable state, right? So with this, we are going to discuss our next topic, that is embolism, right? And this is going to be really simple one, and you have a lot of UWorld MCQ on that. I'll be discussing the respective MCQs along with that. Embolism. What is embolism? Yes, anyone? So simple.
Embolism is, it's an abstraction or blockage of blood vessels.
Okay, so can I? Okay, we discuss a thrombus, right? We
Uh-huh.
discuss a thrombus. Whenever this thrombus is cut off from the blood vessel surface, and it just keep on moving inside your circulation, that's simply known as embolism, right? It have
Yes.
embolized and it moves to certain other structure, right? Or
Yes.
simply you can just remember that the word ambulance is like same as ambulance, right?
Yeah.
An ambulance basically moves, right? It like moves everywhere on the roads. It keeps on moving, right? So simply you can just think of embolism like that. Okay, so we can have embolism of different things, right? Like we can have the blood clot or thrombus. In this case, it can embolize, it can go, it can enter different
Yeah.
structure. For example, we discussed paradoxical emboli. If an individual is having atrial septal defect, it can enter into your circulation, and it can enter you into your brain, causing infarction. It can enter into your renal system, causing infarction there. Or okay, we can also have embolism of different other things. For example, fat embolism, right? Fat embolism. So how can we have fat embolism?
After bone fracture.
Perfect. So we have a UWorld MCQ in MSK module, right? In the MSK module, you are going to see the same MCQ. They're going to give you in the history, we have an individual, she have a pelvic fracture. So we know in the bone, we have bone marrow, right?
Yeah.
Bone marrow
More
is
fat.
like you can consider it as a
It's
fat.
yeah.
It's fatty, right?
Sugar.
So it can also embolize. Simply think, yes, we can also have gas embolism. For example, if an individual is having like laparoscopic surgery, we are basically inserting like a gas in his abdomen in order to like look for the like in order to distend his abdomen. Or for example, if you are using like electrocautery, we can just we can have development of gas there, and this gas can enter into a blood vessel. It can embolize and it can cause problems, right? Okay, we also have a phenomena that is known as decompressive, right? Decompression. Like for example, in deep sea divers, once they're approaching to the surface of land, they can also have nitrogen gas precipitate, right? That
Yes.
nitrogen gas can enter your blood and it can cause embolism. So what's the idea? The idea is really simple, right? So okay, can anyone just tell me why do we have nitrogen gas embolus and deep sea divers once they are approaching to the surface of the land? Anyone who can just tell me the reason why? Yes, please raise your hands. Yes, Dr. Ramiz. Hello, Dr. Ramiz, are you here?
Can you say again, please, sir?
Okay, so we discussed that we can have gas embolism, right? So normally
Yes.
we can see a specific type of gas emboli, which is nitrogen gas emboli, right? And this kind of emboli is basically seen in deep divers, right? Those who are like diving deep into the oceans. So if once they are approaching back to the land, right, they are coming to the surface. So what happens? Nitrogen gas can just come out in their blood, and it can embolize and it can give you gas embolism. So
Yes.
my question is that why are we getting like getting embolus once they are like approaching to the land, or once they are like decompressing? Okay, so the idea is very simple. For example, if you have an individual, right, he's diving deep. What happens that as he's going deep, the pressure surrounding him is going to be increased, right? So
Yes.
normally we know that nitrogen is basically present maximum in our air. That is 78% of the air is nitrogen, right? The air which we are basically inhaling, right? So what happens that if he have air in his let's suppose lungs, once he's just going down, so basically the pressure in surrounding this individual who is just coming down and down in the ocean, basically it's going to like take all the air, right? So the pressure of the air is also going to be increased. The partial pressure of nitrogen is increased. It's going to leak into the blood, right?
Yes, sir.
Okay, so nothing would happen if he's present here, right? Because it's in the blood, nothing is happening. But once he's approaching back to the land, now it can be simply think of, like for example, if you have a soda bottle, right? So what happens in a soda bottle? Basically, we are adding gas, carbon dioxide. You already know that, right? Hello?
Mm-hmm.
By force, by pressure, we are adding carbon dioxide by pressure, right? So you can just consider it same as this case. Once this individual is going down, basically you are increasing, or you are adding nitrogen into his blood. Why? Due to increased pressure, as we are here doing in the soda bottle, right?
Yes.
Okay, so once this guy approaching the land, now what happens? Now he's moving towards less pressure, right?
Uh-huh.
Right? So it's the same as I'm just removing the bottle cap. I'm just decreasing the pressure. So what happens? All of the gas is going to move out, right?
Uh-huh.
Right. So once this individual is moved out, it can be simply think of that you are just removing the soda bottle cap. So all of the nitrogen is going to move. It's going to embolize, which is going to give you gas embolism. Is that clear? This gas
Yes.
can
Yes.
precipitate in the blood. It can embolize. It can precipitate in the joints, and
Yes.
that's all. Do you guys get that?
Yes, sir.
Yes,
But
doc-
can homocystinuria give thrombus?
Yes, we discussed that because homocystinuria.
Yes, sir. Can it lead to
Okay,
thrombus formation?
okay. So the answer for that is very simple, right? What is homocystinuria? We are just removing homocysteine, right?
Yes, sir.
If I'm just removing this thing which is causing toxicity, if I'm just eliminating it, so what do you think?
Okay, that means it won't cause it, right?
Yeah, yes, perfect, right? Okay, so let's discuss our last topic, that is pulmonary embolism. We already know that. We have discussed it in different modules. Okay, just give me a second. Just give me 1 second, please. Right? Hello? Hello, can you guys hear me now? Hello?
Yeah.
Okay. So basically, Dr. Varda is asking that how can we have nitrogen embolism in like deep sea diver once they are approaching back to the land? So can anyone just give a good explanation for that?
Doctor, can I try?
Oh, yes, please, but a little bit slow that Dr. Varda. Yes, Dr. Varda, please turn on your mic. So now Dr. Muskan is going to be teaching this topic and you can just ask her questions, right? Yes.
Okay. So basically, what's happening?
So I asked the question was that how can a diver avoid formation of the nitrogen embolism?
Okay, so that's a good question, right? So the answer for that is just he should just stay in home. He should not dive so deep.
Excuse me? He should dive up slowly?
He should not dive so deep, right? He should not increase
No,
so.
doctor, I think if he will not do the rapid accent, so I
Yeah.
guess in this
Okay.
situation,
Okay.
everyone.
Yes. The idea is really simple. Like I was just kidding. So he should not like have a rapid ascent, right? He should just come slow, right? The idea was basically like you can just relate it with a soda bottle. Once you are just opening it directly, you are going to see a like a pop of gases coming out, like But if you are just opening it slowly, calmly, so what happened? There won't be like that level of emboli being seen, or that level of nitrogen like being circulating and things, right? So did you get that? Hello?
Yes, thank you so much. I
Okay.
got it.
Okay, so let's discuss pulmonary embolism, right? So what happens in pulmonary embolism, the idea is really simple. For example, if we have deep vein thrombus, right? It dislodges, it will just become emboli, right? Hello?
Yes.
Yes, doc.
From the vein, blood goes to the heart, right? We discussed that. Hello?
Yes,
Okay.
doctor.
Inside the
Yes, doc.
heart, it's first of all going to come into right atrium, right? From the right atrium, it would enter left.
Right ventricle.
Right. Okay. Right ventricle.
Right. Yeah.
Perfect. Okay. Right ventricle. From the right ventricle, it's going to go into pulmonary artery, right? Okay. From the pulmonary artery, it's going to, it's going to enter into small arteries, basically the divisions of pulmonary artery, and stuck there, right? And it would end in a condition which is known as pulmonary embolism. And pulmonary embolism, we are going to see dyspnea, we already discussed. We are going to see VQ mismatch. As now we do not have perfusion with a lot of ventilation, is going to be known as a condition which is called as dead space, right?
Yes, right.
Hello?
Yes, doctor.
Yes,
Right.
we discussed that. Okay, so this was a brief overview of pulmonary embolism. You should just know the pathway. And with this, the discussion come to an end. And we are going to have 5 minutes of break. And right after that, Dr. Taha is going to continue the session for your questions. Okay, thank you so much. So I have some work to do. Hope so you guys enjoyed my lecture today. And I was just staying here for quite a lot of time. So I'll just have this discussion to Dr. Taha for the remaining UWorld questions. And in the end, you guys are going to do the the remaining 9 questions. So we have a total of 25 or 29 questions today. Okay, let me just tell you how have we just divided the questions and how do we arrange the task. So all of our tutor today just took a big meeting, and we have decided in today's UWorld questions, first of all, you are going to see MCQs in today's session. You were having MCQs from yesterday topics, right? Okay, so right after this session, you are going to have MCQs from today topics, right? That is a DIC. You're also going to have MCQs from the pharmacology in tomorrow's session, right? So everything is almost covered, and if there is some problem, so Dr. Taha is there to help you, and the remaining 9 MCQs are going to be your own tasks. And those who have missed the announcement, soon we are going to launch the Discord server for our next generation USMLE family, and you guys can then have sessions there, and Dr. Maheen is going to host those sessions, right? So thank you so much. Let me just call Dr. Taha. Dr. Taha, are you here?
Dr. Ahmed, is it possible to share the link of your notes or a screenshot of it?
Actually, I don't know how to take I think I'm just writing down the notes. Okay, I'll
Yes,
just take
yes.
screenshot and I'll
You
just.
can save it as a PDF. This one. There is
Okay,
a.
okay. I'll do. Okay, so my team, I'll just give it to my team. I'm not very pro at that, so Dr. Hamza is going to do that for me, and I'll definitely just share that. Right?
Thank you.
Okay, so I'm just calling Dr. Taha. I think he have enough rest, and now I have to take the rest. And in the end, I'll just mute you. You guys can just drop down your review. And thanks for staying here. So like we have a lot of participants. So are you guys enjoying this new experience? Hello.
It's amazing, sir. Thanks so much.
If you guys have any suggestions, if you guys have any, it's a family. I won't say that it's a platform and we are going to implement things. So whatever is best for you, whatever suits you, this was an effort which our team made, right? If you guys have some deficiencies, if you guys are thinking that we can improve further, you can like just drop down your feedbacks, right? So that's all. And another thing I'm just announcing again and again, in order to like go with our tasks, just please follow the official UWorld, as the UWorld have granted us an institutional subscription discount. So please do participate in that. And another thing, just believe in the schedule. This time, believe in your mentors, Dr. Maheen, Dr. Taha, me as well, and just follow the schedule. Don't burden up yourself, because believe me that it's a big journey still remaining, and you guys don't have to drain out yourself, because it's not only about like having knowledge, like having a bunch of knowledge, doing a lot of UWorld questionnaires. It's all about absorbing the knowledge, right? So this time we have like a perfect schedule to follow, and we have like perfect mentors available. And soon, like some of other my friends who are resident there, they'll also be joining the classes. They are going to help you all for free. So this time you are going to pass the step one exam, right? Thank you so much. Any feedback would be highly
Thank you.
appreciated.
Thank you, Dr. Ahmed.
Thank you so much. Okay, so I'm just okay. Let's have 5 minutes of break, and then Dr. Taha is going to come, right?